acute care nurse practitioner at ICU, is addressing intracranial hypertension. Thanks, Dina.
So I was asked to talk about intracranial hypertension. So this is a subset of neurocritical care, which is an area that I basically used to work in at a comprehensive stroke center. So we used to care for a lot of patients who had issues that would result in intracranial hypertension. And I guess that's why they asked me to speak about this topic today, because somebody thought I had some good experience. So basically, what I decided to do with this, because when I was trying to put this talk together, was basically I put it together for the nurses here in a community hospital, basically what it is, what to look for, and what they would be expected to start doing once they get orders, if a patient comes in and they have something like this. So in this hospital, chances are patients, you would see them in the ER or in the ICU. They may develop it. There is possibility of it happening on the floor, but it would be more of an acute setting where they would end up with an intracranial hypertension. So what I did here was basically just, to know the abnormal, you should know what the normals are. So the normal ICP is basically from 5 to 15, and you would start treatment in patients with intracranial hypertension if it's sustained above 20 millimeters of mercury. So there's two doctors who came up with the Monro-Kelly hypothesis or doctrine, which basically says that the intracranial compartment contains a fixed total volume determined by the rigid skull. So it's basically what you have to do is think of the skull like a box. And it's a closed box that doesn't get any bigger or any smaller. And there is a set volume that the box can hold. And our autoregulatory mechanisms will basically compensate. So if one thing goes up, another one would compensate and go down except for the brain matter itself. So if you have like an increase, something that increases blood flow, essentially there would be a type of autoregulatory mechanism that would cause the CSF to decrease and vice versa. So it's once that's disrupted is when you develop intracranial hypertension. So normally we can have transient increases. So this can happen if you're coughing. If you're laying down, you can get a transient increase, or even if you vasovagal and bear down, you can get a transient increase. But if you have normal compensatory mechanisms, then the pressures will basically go back to normal and you're not affected. It's when you have a decreased compliance and you have large changes in the pressures, if something obstructs the outflow of blood or CSF out of the brain out of the skull is when you start to have issues with this intracranial hypertension. So this is just basic causes that you can have intracranially. You can have a mass, traumatic brain injury, or just non-traumatic ICH strokes. It's usually the larger strokes that'll cause someone to have really increased ICPs, like the hemispheric ischemic strokes, hydrocephalus, and just like benign changes. Extracranial causes like airway obstruction, hypoxia, basically anything that's going to cause you to have a decreased venous flow out of the brain. Also, fevers in these patients. So if you have a neuro patient, say someone who comes in with a large traumatic brain injury, if they have fevers, that can contribute to the hypertension because it's increasing the metabolic rate. So you want to do everything that you can to decrease or basically keep them like normothermic and decrease the metabolic rate. Seizures can cause an increase, can cause hypertension as well as drug use. Postoperatively, if you have patients who have edema, increased cerebral blood volume, and disturbances of the CSF. So one of the most important things with all of the neuro patients is their exam. And to know this, you should know the Glasgow-Coma scale, because you want to know if your patients are basically getting worse or if they're improving based on on anything that you do with them. So if you have someone who's awake and alert and talking to you and listening to you, then they're more awake and they have more of a mild issue with their mental status. You basically get a 3 just for showing up, so you can never score less than a 3. But it's good to know because if you have a patient who's awake, you want to know if they start to decompensate, where they are and how much worse they're getting and what's going on, and do you have to intervene? Or if you have someone who's severe and you perform an intervention, you want to know if they're getting better, the same, or even if they're getting worse. So, and generally what you would do is with these patients, so if you have someone come in and you do a Glasgow Coma Scale and, say the mantra that we learned with these types of patients that was ingrained into my head was less than 8, you intubate the patient. So you want to intubate the patient for airway to secure their airway. So their lungs may be great, they're oxygenating great, but if they're sitting there just slumped over in the bed and they'll wake up every once in a while, chances are they're aspirating and you're gonna run into bigger problems than you've already had. So what I did was, this is basically how these patients will present. So they'll more than likely have a decreased level of consciousness, and they'll be hypertensive with or without bradycardia. So you may have someone who's awake and talking to you, or you can have someone who's sleeping and they'll wake up every once in a while and talk to you, or you could have someone who's just completely obtunded, not speaking to you. So there's really a wide range of how the patients will come in, and it really depends on what's going on in their head. One time we had a patient who came in, and she came in as she had like a Hunt Hess, like a grade 2 subarachnoid hemorrhage. But she had a CT that was full of blood, basically like bilateral intraventricular hemorrhage, like classic circle of Willis, but she was awake and talking. So she came up to the unit and we just monitored her, but we were waiting for her to catch up to the scan. So it took her a couple of days, I guess at the point where, after 72 hours where they have the maximum swelling, and she wound up decompensating, and she wound up we had to intubate her, and she had to wound up with an EVD in her head. But so it's just, it's always important to know how they're going to look, and even like what their tests look like, because their exam may not always match the scans, but eventually they will catch up. Sometimes you'll see these patients have headaches, they'll be vomiting, it would likely be like a projectile vomiting, papilledema, and 6th cranial nerve palsy. I don't know how many people actually look into the patient's eyes in the ER to see if they have papilledema, but it is something that is present. So Cushing's triad is, everyone always talks about it in nursing school. Basically, this is what happens. You'll have the bradycardia, irregular respirations, and a wide impulse pressure. So the only problem with this part of the clinical exam is this is a late sign of an elevated ICP, and your patient is already not going to do well, and likely are herniating and progressing to brain death, because these are symptoms of a brainstem herniation. So if you see your patient and they're exhibiting this exam when you're doing an exam on them, they're in trouble. And you should call Live on New York.
Yeah.
So different types of herniation syndromes that can cause, that'll be caused by elevated ICPs. So you have uncal herniation, posterior fossa, which is cerebellotonsillar, and upward herniation. So this is basically just a picture of the different types of herniation syndromes that you could get. Just so you can sort of visualize what's actually happening with the brain. And then this is just another one also. So the transtentorial or the uncal herniation, which is probably one that everyone knows. I feel like that's the most common one that you hear about. You'll have the medial temporal lobe displays downward through the temporal incisura, compression of the ipsilateral oculomotor nerve followed by the midbrain. So they'll have ipsilateral dilation of the pupil that'll progress to extensor posturing and a depressed mental status. So anytime your patient starts to have a depressed mental status and they start posturing, that's not a good thing. Out is bad, in is okay, it's better. So this is the one basically with the uncal herniation, it'll radiate out towards that way. And then you have bilateral transtentorial herniation, which is a central herniation syndrome. patients will get this if they have a global cerebral edema, and they'll have coma, extensor posturing, bilateral fixed and dilated pupils. This is fatal. Upward herniation is a posterior fossa herniation syndrome, so it happens with the cerebellum. And the cerebellum will move up through the tentorial opening and cause obstruction of the third ventricle. So this is especially important, especially when patients have a cerebellar hemorrhage. So this is the type of patient that if they have any type of ventricular obstruction, you wouldn't just put an EVD in the patient because they'll have upward herniation. So if you see a patient who has a cerebellar hemorrhage, they would have to do a decompressive craniectomy in addition to putting the EVD in order to avoid this herniation syndrome from happening and basically making the patient worse off versus helping them. And then cerebellar tonsillar is basically its downward displacement of the cerebellar tonsils through the foramen magnum. So the late signs of this is an elevated ICP pupillary changes. So you would give osmotic therapy, hyperventilation would be a temporizing measure, and decompression is a definitive one. So treatment of the elevated ICP really depends on why is the ICP elevated. So that's really what you would have to know what's happening in order to know what to do with the patient or what to expect the type of orders that you're going to receive. So what I have found to be very helpful, and this is available basically to anyone online, is the Neurocritical Care Society has basically what they put it out a couple of years ago. It's called Emergency Neurological Life Support, so it's ENLS, and it's basically similar to like an ACLS or a BLS, except for it's all about different types of brain syndromes and what to do. Basically, it's like within the golden hour of patients who have emergency neurological situations. So especially like, in a place like this where we don't necessarily see a lot of patients who may have like a large subarachnoid hemorrhage or large like a traumatic brain injury, they probably wouldn't come to us, but in the event of if they did, if you're not sure, this is available online. And they basically have the different algorithms that you can go through and you can get certified. They have like a certification course. So this is basically outlining their version of what to do when patients have an elevated ICP or if they have a type of herniation syndrome. So you would see this would be a useful tool in the emergency room or even in the ICUs or if patients are on the floor, but it's good to know just, what can I do and what should I be expecting, what should I set up for as a bedside nurse to do with my patient. So it has basically a tier 0, which is standard measures, tier 1, and then it progresses to tier 2 and tier 3. Basically the tier 0 is, just you have someone who comes in with an elevated ICP and basically had a fed up. I'm going to go through everything in detail, but it's like the lowest level to progression to the highest level of pentabarb comas. And so the first line therapies, which would be their tier 0, is just you want to reposition the patient. Does anybody know how to position the patient if they came in with an elevated ICP? Thoughts, anyone?
Elevate their head
Yes.
and keep the head straight.
Yeah, so you want to keep them up to help ensure the venous return out of the brain. So this is why a lot of neurosurgeons don't like their patients to have IJs, because they feel that it decreases the flow out of the brain. You would also intubate the patient if their GCS is less than 8 intubate. And then you would do maneuvers with sedation and analgesia. So where I was when we had patients who would come in, we would try and steer away from narcotics because it could blunt your neurological exam. And we would use a lot more propofol because it's easy on and they'll come off and they'll wake up and come out of it and you'll be able to examine them. But it's good to keep in mind that these patients, blood in the head or those pressure in your head, if the patients are awake, they're in pain. So you just want to make sure that you treat that as well. So second line treatment, so basically what you do is you move from one tier, you move on to the next. So if you perform those maneuvers and the patients are still acting as if they have their elevated ICPs, their neuroexam still isn't good. You can try things like hypertonic saline and mannitol. So these are the osmotic agents. So the mannitol used to be the gold standard for this, but now there's a lot of data and papers coming out that hypertonic saline is superior to mannitol. So you can use, there's 2%, 3%, and the 23.4%. So if you're giving the hypertonics, you want to make sure that the patients have a central line, especially if you're doing 23% bullets. And mannitol you can generally give through a peripheral line, usually with a filter. The hypertonic saline can be given as an infusion, slowly, or you can give it with a bolus. It depends on what's going on with the patient and basically who's doing it. So the neurosurgeons that we used to work with would like the patients to have it over a period of time, and they would target like a higher sodium level. And then the trauma surgeons that I worked with preferred to do boluses. So it really depends, but the 23% is basically just a push through so that you wouldn't infuse over a period of time, like you would with the hypertonic saline. And then you also, if you're infusing the hypertonic saline or giving mannitol with the osmotic agents, you just want to monitor the serum osmolality to make sure that it's actually going to be effective. So the next thing you can also do is, if your patient's intubated, you would do hyperventilation, but this is a transient thing, and it won't keep your ICPs down. You basically have to do this as a bridge to another therapy, like either CSF diversion, or if they wind up if they're a candidate to go to the OR. So ventriculostomy, this is basically just a picture of the ventricles and the flow that you would have. So ventriculostomies, we don't really see much of these here at all. Let me see, actually. So we used to, where I came from, almost every patient in our unit would have a brain drain like this, especially those who came in with the subarachnoid hemorrhages, because they would likely develop an obstructive hydrocephalus. So they would sit in our unit with these drains in for up to 2 to 3 weeks. And we were monitoring them for vasospasm. So the good thing about there are multiple different types of drains you can, monitors you can use in order to keep track of what your patient's ICP is. But the thing with the ventriculostomy and why it's more popular than the bolts and like the intraparenchymal drains is you can monitor and you can also drain. So I just threw that out there in case, in the event of if anyone came in so severe and the neurosurgeons decided to throw a drain in, which I highly doubt would happen, but you never know. And then you would have someone come down from nursing education to teach you how to hook it up and use it. Indicators for ICP monitoring. So it would be severe traumatic brain injury with an abnormal head CT, or severe traumatic brain injury with a normal CT if they have at least 2 of the following, which is if they're over 40, of hypotensive with a blood pressure of the systolic less than 90, and abnormal posturing. Or if they have like a subarachnoid hemorrhage with the hydrocephalus, you would monitor also. So I threw the ICP waveforms in here just so everyone can see them. I don't know that anyone's familiar with them, or if they are, that will really even see them, but just, it's important to know that it's the three waves. This is the normal one. I just put it up here so everyone could see the normal and the abnormal. So the normal is basically, it would be like, even if you compare it to like the arterial waveform, you have like your mountain that's going down. But if you have the peak in the middle, your brain is not compliant and there's something going on, so you're going to have the increased pressures. And if you go from a normal to an abnormal waveform, it's important to let the providers know that there's a change in the patient. I mean, you'll likely see the increase in the pressures as well with this, and I'm sure there would be a change in exam, even if it's a subtle one. So third line of treatment would be metabolic suppression with anesthetics, pentobarb combers, and titrate to a burst suppression. But you would put the patient on a continuous EEG monitor. This obviously we wouldn't do here, and the patients would be transferred to a tertiary facility. But it's just good to know what type of treatments the patients may need to have. You would induce hypothermia and possibly do surgical decompression. So the Rescue ICP, I threw this in here also because Rescue ICP trial basically assessed medical treatment, which is everything that we just reviewed, versus a surgical decompression in patients with traumatic brain injury. And it showed that there was a lower rate of mortality in patients that did have the decompression, but they had higher rates of vegetative states. And although they had lower rates of severe disability, they still had disability and they weren't necessarily going home after these decompressions.
I mean, that could be just because they survived, but they're
Yeah.
not.
Yeah. So we had a patient one time who had a surgical decompression, and it was a 30-something-year-old, and wound up needing VP shunts and everything, left, and he wound up coming back and needing like revisions, but he was just basically living in a nursing home. He wasn't even in a rehab facility. He was just, just there. So, so it's basically it's just helping you to be able to basically have your brain swelling. They'll take the brain off to relieve the pressures, but it's not really doing anything for their quality per se, versus giving them quantity of life. So the nursing interventions with these patients, and basically the types of interventions that we can do here, especially like in the ER before patients are going off to other facilities or being transferred. You want to do frequent neurological assessments to know, is my patient changing? Are they getting worse? Are they responding to the treatments that we're giving them? Maintaining adequate airways and hemodynamics, ICP monitoring if indicated, fever management. So with the neuro patients, it's important to treat the fevers because they can help to decrease the metabolic rate. So these are probably one of the few patients that I'll actually be aggressive with in treating their fevers. IV fluids to keep them eubulemic, you want to watch their BGMs, administer nutrition, and anti-epileptics if indicated. So this, usually with trauma patients, you'll give them more subdurals. If they didn't seize, you would give 7 days of anti-epileptics and stop them, but if they did seize, then you would have to do treatment. So it's very rare that I think that we would see patients who really have like severe require intensive treatment here, but it's just good to know because if you don't do it often, it's not as easy as it is. So where I came from, we were basically a tertiary center and we were a referral center, so the patients that we send out are patients that we would get, and we would take care of these patients all the time. And when you have everything in place, it works seamlessly. When you have IR and neurosurgery and the ICU and everyone works together, it makes it seamless and easy, and it's like you're a well-greased machine. But when you're not doing it all the time, it can be a little difficult, especially if you're not sure of what to do. It's the first time you're seeing it, you don't see it frequently enough. So it's just important just to know the basic things, and if you're ever not sure, those protocols are right online. You can just pop it right on Google and pop up, just Google ENLS protocols, and you can pop them up and everything's there for you, and it's basically step by step on what to do, so you know what to expect when the orders come in. And I felt this is important to put up just because the patients who have the elevated ICP, they're not necessarily dead yet, but they do have a high risk for progressing to brain death. And these are the patients that you should be referring to Live On New York. They don't necessarily have to be dead or brain dead yet. It's just good so that you don't miss a referral. So the criteria basically is either every cardiac death or a mechanically ventilated patient who has absence of 2 or more brainstem reflexes, Glasgow Coma scale less than or equals to 5, or if there has been discussion with the families to withdraw treatment. So it's just important. Like we would get these patients coming with severe, we got a lot of aneurysmal subarachnoid hemorrhages. So if they would come in with a ton of blood in their head and intubated, sedated, they were with us for a long time. You just let them know, I have this type of patient that's here, they're intubated, they're not doing well, and then they usually just say, okay, they give you a referral number, let you know, they tell you, call us if the patient gets any worse or if there's any discussion of withdrawal of care. It can save a life, so, it's important just to know that. And that's really Does anybody have any questions? I have boatloads of stories, but, yeah, so.
What is